Hi everybody, welcome to our module on the MEN syndromes. MEN stands for multiple endocrine neoplasia, and the MEN syndromes are a group of very rare genetic disorders that run through families in an autosomal dominant fashion. They all involve germline mutations to genes, we'll talk about what that means in a minute, and they lead to tumors in multiple endocrine glands, hence the name multiple endocrine neoplasia. And there are actually a number of these syndromes, but the three that are important for you to know as a medical student are the MEN1 syndrome and the 2A and 2B syndromes. We'll start with the MEN1 syndrome, and patients and families who have the MEN1 syndrome develop tumors in multiple endocrine glands that can be remembered by the mnemonic the 3Ps. The 3Ps stand for pituitary adenoma, parathyroid adenoma, and pancreatic tumors, and I've shown that on this picture on the right side of the screen here. The MEN1 syndrome is an autosomal dominant syndrome, just like all of the MEN syndromes, and it results from a germline mutation in a gene called the MEN1 gene, which can be found on chromosome 11. This gene codes for a protein called menin, which functions as a tumor suppressor. So if you have abnormal MEN1 genes, you will have abnormal menin, which will not function properly, and therefore you will lack the normal tumor suppressor function of menin. This is a classic example of the two-hit hypothesis of gene mutation and cancer development. Patients with this condition are born with the germline mutation of MEN1, meaning they are born with one abnormal copy of the MEN1 gene. However, they have another copy that is functioning normally. At some point later in life, a second hit occurs and results in damage to the other copy of the MEN1 gene, and this leads to tumors in the endocrine glands. The tumors that occur in the MEN1 syndrome are the three Ps, and the first P is parathyroid adenoma. This occurs in 94% of patients, and it is the first finding in about 90% of patients. And you should remember this because this is the way MEN1 will often be described in a board question. It will be a patient who presents with a parathyroid adenoma and also has other tumors and a family history of other endocrine tumors. The parathyroid adenoma will present the way any parathyroid adenoma presents, which is as hyperparathyroidism. I talk about this in a separate module, but hyperparathyroidism is often detected when asymptomatic, and it can present with recurrent kidney stones from hypercalcemia. The second P of the MEN1 syndrome is a pituitary adenoma. This occurs in up to 70% of patients. Most commonly, it is a prolactin-secreting tumor. Second most commonly, it is a growth hormone-secreting adenoma. And one thing that's very helpful to remember in answering board questions about the MEN syndromes is that pituitary adenomas are generally not seen in the MEN2 syndrome. So if they are describing pituitary disease in a patient or in a family with multiple endocrine neoplasias, they're usually talking about MEN type 1. The third P in MEN1 is pancreatic duodenal neuroendocrine tumors. They are called this because they can arise in the pancreas or the duodenum, and they are neuroendocrine, meaning that they often release hormones. Most commonly, these are gastrinomas, and they can lead to the Zollinger-Ellison syndrome, which I talk about in other videos. This syndrome involves multiple peptic ulcers. Besides gastrinomas, they can rarely be other types of neuroendocrine tumors, things like insulinomas, glucagonomas, or VIPomas. Moving on, let's talk about the MEN2A and 2B syndromes. These two syndromes are very similar, and they both involve what I call medullary tumors. This is an easy way to remember the tumors of 2A and 2B. Both 2A and 2B result in medullary thyroid carcinoma and also pheochromocytoma, which you may know is a tumor of the adrenal medulla. So if you just remember that 2A and 2B involve medullary tumors, it can help remind you that thyroid and pheochromocytoma tumors are common to both disorders. Patients with the MEN2A syndrome have the two medullary tumors plus parathyroid adenomas, just like we described before in MEN type 1. And importantly, the MEN2A syndrome does not involve any physical findings like you see in 2B. In MEN2B, patients develop the two medullary tumors plus what I call the M's. The M's are two key phenotypic findings that you can see on physical exam. These patients have neuromas of their mucosa, which we'll talk about in a minute, and they also have a Marfanoid appearance, which means an appearance similar to the Marfan syndrome. And importantly, the 2B patients usually have no parathyroid involvement. Parathyroid only occurs in the 2A syndrome. So let's talk about the features of MEN2A and 2B one at a time. The first feature is medullary thyroid cancer. This is a cancer of the parafollicular C cells in the thyroid. I talk about this in more detail in the module on thyroid malignancies. One thing that's important to remember about medullary thyroid carcinoma is that these cancers can produce calcitonin, which lowers serum calcium. Under normal physiologic conditions, this has a minimal effect on calcium levels. However, if you develop a medullary thyroid carcinoma, you can get hypocalcemia. As I said before, medullary thyroid cancer occurs in both the 2A and 2B syndromes, and when it does occur, it develops earlier than in patients who have sporadic medullary thyroid cancer. If you have a sporadic cancer This usually develops in the 60s. Patients who have the MEN syndromes get this cancer in their 30s. And there's a 100% lifetime risk of developing this type of thyroid cancer. And we'll talk about this later, but patients with the 2A and 2B syndrome often have their thyroid gland prophylactically removed. Now, I told you before that patients with the MEN 2A and 2B syndromes get pheochromocytomas as well. This usually occurs after medullary thyroid cancer. Medullary thyroid cancer usually occurs first. Remember that MEN 2B syndrome has the same two medullary cancers as 2A. The difference in 2B is that there is usually no parathyroid involvement, and there are two key physical exam findings. The first finding that you see only in MEN 2B is the presence of neuromas on the mucosa of the lips and the tongue, and the second is a marfanoid body habitus. So neuromas are benign growths of nerve tissue. These will occur in the MEN 2B syndrome under the mucosa of the lips and the tongue. Patients will present complaining of a bump on their lips or on their tongue. Sometimes these patients also have intestinal neuromas that are detected on endoscopy. Patients with the MEN 2B syndrome have a marfanoid appearance, which means they look like they have Marfan syndrome, so they are very tall with a long wingspan. They also tend to have a high arched palate, and they often have skeletal deformities of their spine. They can have a kyphoscoliosis, which is a curve to the left or right, and they can also have a lordosis, which means their spine is curved forward. You do not see involvement of the lens of the eye or the aorta in patients with MEN 2B like you do in Marfan syndrome. Mostly what is meant by the marfanoid appearance is that they are very tall with a long wingspan. That's usually a tip-off that the patient may have MEN 2B. Just like MEN 1, MEN 2A and 2B are autosomal dominant disorders. Children born with one of these syndromes have a germline mutation in their RET gene found on chromosome 10. The RET gene is a proto-oncogene that codes for a receptor tyrosine kinase that's important for cell growth and differentiation. In the MEN2 syndromes, there is a gain of function of the RET gene, and that leads to the development of cancer. And you can contrast this with Hirschsprung's disease of the colon. The RET gene has also been implicated in Hirschsprung's disease, but in that situation, there's a loss of function of the RET gene. In MEN 2A and 2B, there is a gain of function. And I mentioned this before, but I just want to emphasize this point because it often comes up on board exams. Patients with the MEN2 syndromes often have a prophylactic thyroidectomy. As I said before, the risk of thyroid cancer over the lifetime is virtually 100%. So in families who have these gene mutations, many of the children will have a thyroidectomy at a young age, often less than 5 years old. And from that point forward, they can take thyroid hormone supplements. I'll finish with this slide, which lists some important points to remember about the MEN syndromes. First of all, remember that if you see a description of a pituitary adenoma, they're talking about MEN1. Pituitary involvement only occurs in MEN1. If you see a description of medullary thyroid carcinoma or pheochromocytoma, then they are talking about 2A or 2B. Those two types of tumors occur in both of the MEN2 syndromes. If you see a description of parathyroid gland involvement, that could represent the MEN type 1 syndrome, but also the MEN2A. And then finally, the other features of the different syndromes are shown on the slide here. MEN1 also involves the pancreatic duodenal tumors, and MEN2B involves the mucosal neuromas and the marfanoid body habitus. And that concludes our module on the MEN syndromes.